the shift to the medical model. So we'll get right into it here. Oh, hang on. Ooh, there we go. Technical difficulties. All right, so like these images here of dentistry over time, thankfully, we have evolved a lot. So from the look of our practices, both inside and out, and the technology that we have at our fingertips is thankfully so much better than it once was. But what I'd like to ask is how much has changed in our hygiene operatories? Is it a lot? Is it a little? Definitely from the way that we treat is, but from a diagnostic standpoint, maybe not so much. So I was recently having a conversation with my mom about her hygiene visit, and I was asking her, how much has changed, Mom, in the last 10, 20 years when it comes to going in to get your teeth cleaned? And she kind of hemmed and hawed about it for a while and kind of came up short. And she was like, well, it's a lot more comfortable than it used to be. There's a lot better technology now, but it really isn't that different. So, what is our patient's perception of what we as the hygienists are really doing in there? And why is that? And why is that perception perhaps just kind of the same as what it once was? And so really looking at the mouth from a bacteria standpoint, I think is the key. So thinking about our mouth in a different way. So our mouth houses the second most diverse microbial community in the body, harboring over 700 species of bacteria that colonize the hard surfaces of the teeth and the soft surfaces of the oral mucosa. So it's bound to for us to think that there's probably going to be some infection and some bad bugs that get a hold of us once in a while. And so, oh, my screen got stuck. Here we go. So thinking about periodontal disease and all those bacteria that are all over our bodies, and of course, not all of them are bad, only if some of them are bad. So the Center for Disease Control did the largest study that's been done, and it was back in 2012. And they found that 1 in 2 American adults by age 30 already had periodontal disease. So at that point, already bone loss. And by age 65, it jumped up to 64% to moderate to severe periodontal disease. So with numbers this high, we should expect to see that in our hygiene operatories, let's call it an easy 50% of our patients should have periodontal disease, because this study isn't even referencing gingivitis. So how are we doing? Are 50% of our codes coming out of the hygiene operatories for some type of periodontal procedure? Well, looking at that same year in 2012, we didn't do very good. So ages 19 to 34, 72% prophies. Then ages 35 to 49, 85% prophies. And maybe scariest of all, age 50 to 64, a 95% prophies. Quite a bit of SRP left there. So where is it? So I've come to believe that the SRP is there waiting for us. And the reason is because as a whole, we're still practicing in the past. So we once thought that any amount of plaque could cause infection. So we naturally concluded that removal of as much plaque and calculus would cure the infection. But the problem with this model was that our patients still bled even after treatment. I remember my early days as a hygienist, I just thought that everyone bled. I remember saying it, telling my mom after hygiene school, working for the periodontist, working for a general practice, everyone just bled. And so once I started teaching, and now I've been teaching for over a decade, and I've really come to find that most hygienists felt the same way that I once did, that everyone bled. So I'll ask you, is a little bit of bleeding okay? And then what amount of bleeding is okay? So is it the number of bleeding sites when we probe that determines an active infection? But what if I don't probe as hard as my coworker? Do I then treat less infection? And what if I don't get bleeding on probing, but then I do get bleeding on scaling? Do I then stop in the middle of the appointment and tell my patient I was wrong and that they do in fact have a problem? Or do I just finish the prophy and just tell them they need to floss more? I mean, after all, there's only so much time in a cleaning appointment, right? But the fact of the matter is, no amount of bleeding is okay. And gums should never bleed. And so there's definitely some missing pieces to this periodontal puzzle. And that's why clean doesn't always equal healthy. And I mean, we've all had patients like this one. They come in regularly, their home care is excellent, but once we get in there, it's bloody, even if we've done a gingivitis prophy. So let's take a look at these missing pieces of the puzzle and what we really understand now as far as the cause of gum infections. So it is now understood and recognized that the interaction between the host's immune response and the biofilm are needed to progress gingivitis into periodontal disease. So looking at that in an equation, it looks something like this. So first we have biofilm accumulation, which then causes the inflammation, which is our host immune response. And then that increases the gingival curvicular fluid, which then deprives oxygen in that pocket, which favors the growth of the anaerobic bacteria, resulting in infection. So from there, oh, sorry guys, there we go. I got too many screens up here. Whoops, hang on, there we go. So biofilm. So is this screen up on your guys's too here?
Yep.
All right. Okay. Hang on guys, I got this other screen up here and I can't get it off there.
It looks okay for us, Tosh.
Does it look okay? Okay, great. I've got I had this big screen up there and I didn't want it to be on your guys' screen as well. So
it's perfect.
Okay, great. Sorry guys, I need to get back to biofilm. There we go. I'm an amateur at this Zoom stuff. All right, so the biofilm. So biofilm is not plaque. And so what I tell my patients about biofilm is it's the slimy stuff underneath the gum tissue, not the white fluffy stuff above the gum line. So it's that mixed bacteria and fungi that produces large amounts of slime layer and matrix material. And it also has the ability to have, it has host defense and the ability to cause infection. And so let's look at the anaerobic bacteria. So early biofilm is not a bad thing. The problem comes is when it matures. So the early biofilm is just gram-positive cocci. So that's the healthy mouths, not a big deal. Once it matures though, it turns more into the motile gram-negative rods that are another gram-negative bacteria, which are anaerobic, causing gingivitis and periodontal disease. And the longer it's there, it can overwhelm the good bacteria. So by 3 times. So the other bad news about these bugs is that they don't just stay in our mouth. And so these bacteria have the ability to cross the blood-brain barrier. They can get into our stomach, our heart, all over the body. And some of these bacteria have been found in the innermost arteries of the heart. So really, really bad bugs here. So if they would just stay in our mouth, they could just cause such a limited problem, right? So let's look at this cascade of events again. So first we have biofilm accumulation, which plus the host response then causes the inflammation, which then results in the anaerobic bacteria growth, which then leads to infection or the progression of infection. So all to say that plaque and calculus alone do not cause periodontal disease. So all of these patients have periodontal disease. And so none of them present exactly the same. But if we just treated them all with the same therapy like we used to do, they might not all get healthy. So now that we understand what causes gum infections, what about our patients? So think back to a conversation that you had recently when you used any of these terms on my screen here. They're very much dental terms, not necessarily ones that our patients understand or want to learn. So their eyes glaze over. They just don't want to hear it. And so for us to really explain to our patients what's going on, we first try to teach them our dental terminology. And that really doesn't go very well. So my suggestion is that we stop using dental terms and adopt the same language that their physician uses and use objective parameters that they're already used to. So first, photography. It is so great to just pull the patient's lips back, put a retractor in there and show them what's going on. I mean, usually they self-diagnose from there if there's enough inflammation. And second, phase contrast microscopes. amazing. Being able to show versus tell our patient what's causing their infection is such a game changer. And lastly, salivary lab diagnostics. To really be able to identify and quantify the type of bacteria that's causing this infection is so important. And there's also 5 of these 11 bacteria that are actually resistant to being scaled away, meaning if we're just using traditional SRP, they can recolonize the pocket within 6 weeks. So let's get into just a few case studies here to show you what I mean by this type of care for our patients. So this first patient came to me as a new patient, and her chief concern was that her gums bled every time she brushed. And she was really young, in her early 20s. She had just moved to town, and so she needed a new dentist. And so I asked her what her previous dentist thought the problem was, trying to get a little bit of history. And she said, I just kept being told that I needed to floss more. And she said, honestly, it's getting so uncomfortable to brush because the gum tissue down here is so ulcerated. And so I knew right away, I was like, this is a bacterial infection. And I understand too, there's of course other reasons for a really red mouth. You know, there's dry mouth and acid reflux and all the different things. But the easiest place to start is with the microscope. So I looked under her microscope with her, and lo and behold, spirochete city in there. And she had spinning rods and white blood cells and all kinds of stuff. I mean, her jaw dropped. But she was so excited to find out that there was a reason for her chronic red gums, even though she was doing such a great job with her home care. So we did antimicrobial therapy, we did a lab test on her, and a few weeks later, this is what her gum tissue looked like. I mean, went from bright red fire engine to pale pink. Now, is it perfect? No, it's not perfect, but is it progress? Huge progress, only a few weeks later. And the best part about her story is that she was so excited. She came in, she was like, Tosha, my gums are not bleeding. She's like, they didn't bleed from 3 days after we did that initial treatment. I mean, how amazing. This girl, it changed her life. She was in her early 20s. And so her after slide was amazing. I mean, there's like nothing going on in there, and that's play. I mean, it was like cocci, some plaque. She did still have a few white blood cells. I mean, like I said, it wasn't perfect, but it was excellent progress. And then the next case, good old orthodontic aligners. So sometimes I feel like with orthodontic aligners, it's like, you know, what came first, the chicken or the egg? I mean, was the inflammation there before? Did it get worse with the aligners? I mean, I've had plenty of patients tell me that, oh, my orthodontist said that once they would take the braces off, like it's just going to get better. So when she came in, she had noticed that her aligners were getting really tight on the bottom and they were starting to hurt her gums quite a bit. And she just thought that was part of the process. And so when we took a slide on her, I mean, it was nasty in there. Like there was all kinds of activity, lots and lots and lots of activity. And she actually had a lot of spirochetes too, which isn't quite as apparent on this particular part of that slide. And she was concerned about doing treatment because she had just invested so big in these orthodontic aligners. I mean, many thousands of dollars. But what I shared with her is, you know, it was ultimately up to her what she wanted to do. But my concern is when we move teeth, we're dissolving and regrowing bone. And the risk in not treating this chronic inflammation is that she is going to much more easily end up with recession or black triangles. And so she ultimately said yes to treatment, and her gums, as you can see, looked so much better in only a couple of weeks. And she didn't even realize how red they were to start with. So when you show these side by sides to patients, it's so eye-opening. And so her slide afterwards wasn't perfect. Still a lot of spinning rods, a few spirochetes, but this is only a few weeks later. So much progress. And then lastly here, it was a 59-year-old. She had diabetes for type 1 diabetes for I think about 30 years, clearly bruxism, definitely needs some gum grafting, and she was a dental hygienist. So this is one of the dental hygienists that I taught how to use a microscope chair side. And so when I was trying to grab biofilm from her, it was like impossible. I mean, her home care was immaculate. And I mean, her pocket depths were mostly 2s and 3s and a couple of 4s. Now, granted, there's a lot of attachment loss there, but when we did her slide, she did have a lot of spirochetes, spinning rod, tons of white blood cells. I mean, look at all that bone loss that she's had. And so we did antimicrobial therapy with her. Obviously, it didn't need a lot of scaling because there really wasn't a lot to clean off there. But again, the debris is debris. The debris is not the causative factor here. And so within a couple of weeks, her gum tissue was so much better. And she was shocked at how red her mouth really was. I mean, she thought, you know, being a hygienist, like that her mouth should be so perfect, but she had been doing this with patients at the same time she got healthy. So she completely understood the impact and the change, and to go through it yourself is like so helpful also when you're talking to patients about this. And so her after slide looked great. I mean, very few rods on there, mostly non-motile. It looked so much better. So I'll close with Albert Einstein here and talking about, you know, really thinking about things differently. So I really like to think about, you know, when we know better, we can do better. And for the longest time, you know, in the hygiene department, and for us to pass our clinical boards, it was all about cleaning off the calculus. And so once we get out into practice, we see all this bleeding and we start to think it's normal. And we see patients that don't have deep pockets and we think, well, what can we do for them? And it's still going to bleed. And so really, once you have more tools in your toolbox, like we can just do so much more. So that's my spiel.